Bonjour. Bonjour, Farin.
Bonjour, Antoine.
Ça va bien?
Ça va très bien, merci.
Oui. J'aimerais nous inviter à nous engager dans un dialogue inclusif sur les données en santé. Est-ce que ça te branche?
Ça me branche? Oui, bien sûr.
Dans le fond, la question sur laquelle j'aimerais partir, c'est comme médecin, comme chercheur, une des choses que j'entends souvent, c'est que si on avait davantage accès aux données de santé, on vivrait dans un monde meilleur, les soins de santé seraient mieux, tout irait mieux. Qu'est-ce que tu en penses, toi? Est-ce que ça résonne avec ta propre expérience comme patient?
Pas tout à fait. Mais je vais commencer avec le fait que I'm going to speak in English for this presentation while Antoine continues on in French to represent the diverse nature of our Canadian populations. Getting back to your question, Antoine, I have questions about data itself. And being a peer worker, I'm going to do what peer workers do, and I'm going to speak about my own experience with the health system. And I'm going to do this within the framework of an experience I had over a decade ago. I was hospitalized in April of 2011 and diagnosed with AIDS, or advanced HIV. During this experience, while I was in the hospital, I was put on welfare, much against my desires, because I'm not happy with the welfare system. But I was pretty incapable of doing anything, including protest, so that's what happened. I spent 6 weeks in the hospital before I was released and spent the summer in the day clinic, going in repeatedly for care with a fabulous team of nurses that I really cannot express how much these people are important to the system. But during that time, I came up with a complication involving my Kaposi's. And this led to me having to deal with a doctor that was hell-bent on amputating my foot, which I didn't see in the cards for my future. So at that point, I started protesting. In the end, there was an option that was tried and that succeeded, but that involved chemotherapy. So as well as my day center trips for the regular follow-up, I went through 6 courses of chemotherapy that summer and ended up hospitalized a second time in September of 2011. In November, I went back to work, stating to the welfare agency that I was going back to do 1 day of work per week on a progressive return to work. And by December, I had been cut off welfare, which left me for the next 5 years with an income, or the next 2 years, with an income of about $300, $350 a month to live on while I was recuperating. Being taken off welfare meant that I was homeless for 5 years of my recovery. By March 2012, I was on the street. And I was working 1 day a week for the first 2 years I went back to work, 2 days a week for the year after that, 3 days a week for the year after that. It was finally near the end of 2016, I was back in an apartment. And for me, where I have trouble with this data being something that's contributing to healthcare, I had 3 major questions, well, actually a lot more, but started with the why. Why is this happening to me? And then, why me? Why is this happening to me? And after that, I started getting a little more pointed in my questioning and started asking, well, why would the healthcare system spend so much money and invest so much effort in bringing me back from the brink of death, only so that the welfare system could turn around and put me on the street while I was recovering? And for me, this seemed, in terms of health care, totally irrational. And I'm sure if you had caught me during those 5 years I was on the street, I would have had a different way of expressing that. My words would have been a little stronger. But one of the questions that was really, really definitive in this period was a question that I posed while I was arguing with the welfare agency and trying to convince them to speak to my doctors. And they told me, no, we don't need your doctors. We have our own. And they're looking at your file and they've come to this decision that you are able to work full time, so go to work. But I had to question, like, who are these doctors? What data are they looking at when they make this decision saying I'm ready to go back to work full time? Because for me, that 8-month period between the 2 hospitalizations was incredibly devastating. It was physically devastating. It was emotionally devastating. It was mentally devastating. Spiritually, it was enlightening. That was the one gain I had in health, was that spiritual enlightenment. But for the rest, I didn't understand what they were looking at when they made this decision. I had lost 1/3 of my body mass in a period of 8 weeks. And I wonder, was that data accessible to the decision makers? Or was it hidden so that the decision makers would have to look at the information, the data that was taken when I left the hospital and compare it to data that came from the year before, long before I was hospitalized? Is that how they get to the road of I lost 1/3 of my body mass? Or was it just stated in the data that I had lost 1/3 of my body mass? Was the data in there about the atrophy of my muscles? When I went back to work, one of the expenses I had was buying braces for my wrists because my wrists weren't strong enough to actually do that job 1 day a week. Nothing had prepared me for that muscle atrophy, and nothing that was offered to me in terms of medication or medical care helped me with that problem. There was no physiotherapy. That was left to me to provide for myself. And I was also anemic at this point. And I wonder why these decision makers think that anemia made me qualified to go back to work full time. So there's a whole range of questions, starting with the simple why, and ending with the what data are people looking at when they make decisions about my health?
Pour moi, c'est difficile de prendre la parole après que tu partages cette histoire-là. Farin, la première chose qui me vient, c'est que je suis triste. La deuxième, c'est que ce que j'entends dans ton récit, c'est pas qu'il manquait de données, mais qu'il manquait d'écoute, d'abord. Qu'une partie des données, c'est toi qui l'avais, que tu as essayé de la transmettre, puis qu'il n'y a pas eu d'écoute. Ça me fait penser aussi à une expérience récente dans mon monde de médecin, toute simple, mais qui pour moi reflète un peu le même message. Récemment, on m'a confié les soins d'un patient de 100 ans qui était suivi à ma clinique depuis 30 ans. Puis quand je me suis préparé pour la rencontre, je suis allé dans son dossier, puis il y avait une quantité de données immense sur sa santé. Toutes ses maladies, ses hospitalisations, ses chirurgies, ses médicaments. J'étais capable d'avoir accès à tous les résultats de laboratoire, les imageries, etc. Il y avait une masse de données incroyable. Puis dans notre dossier médical électronique, il y a une toute petite section qui s'appelle « Histoire sociale », dans laquelle il y avait 3 mots. Marié, travaille dans un bureau. 100 ans de vie. J'avais aucune information sur qui était cette personne. C'est quoi ses valeurs? Quelle est son histoire? Qui compte pour lui? Comment il a vécu? Comment il est passé à travers toutes les épreuves de la vie, les deuils? Qu'est-ce qui le fait encore rêver à 100 ans? Comment il voit la fin de sa vie? Qu'est-ce que c'est la mort pour lui? Qu'est-ce que ça veut dire être soigné? Qu'est-ce que c'est des soins qui ont du sens? Qu'est-ce qui compte? Aucune information là-dedans. Comment est-ce que je peux prendre soin de quelqu'un si j'ai juste les données médicales, mais aucune information sur la personne que je soigne? Puis quand je pense à mon ministre de la Santé, j'ai l'impression que son dossier médical ressemble au mien. Il y a des données super raffinées sur les temps d'attente à l'urgence, les listes en chirurgie, le nombre de patients qui reçoivent la chimiothérapie, les coûts détaillés de chacun des soins de santé. Mais les données sur l'itinérance, le logement, l'alimentation, l'environnement, c'est des données qui appartiennent à d'autres ministères. Même si les personnes en situation d'itinérance ont un taux de mortalité 8 à 11 fois supérieur à la population générale, visitent l'urgence 60 fois plus souvent que le reste de la population. C'est comme si on essayait de prendre des données, de prendre des décisions avec un seul œil ouvert. On a l'impression de voir très clair, mais au fond, on est à moitié aveugle. Ce qui m'amène à une autre question, qui est que des fois, on a accès aux mêmes données, mais on ne les voit pas de la même façon, parce qu'on est dans 2 perspectives différentes, comme patient ou comme médecin. Ici, la patiente, elle voit un 6, puis elle est convaincue que c'est un 6, mais docteur, c'est un 6. Vous ne m'écoutez pas, docteur, c'est un 6. Puis le médecin répond, mais non, c'est un 9. Vous voyez bien, vous ne comprenez pas, vous êtes manifestement pas allé à l'école de médecine, c'est un 9 ici. Puis c'est un peu un dialogue de sourds entre les deux. Have you had these kinds of experience, Farin, in your interactions with the healthcare system?
Oh, yeah. Oh, yeah. Arguing with doctors was a full-time job for, like almost 8 months of my life. But it brought me something. I think in the end, what I learned most is that knowledge is actually not based on data, but is based on data that is properly contextualized. And without that contextualization, the data doesn't necessarily give you knowledge. So I went through months and months, actually I went through years of arguing with doctors. I'm still doing it. Because I'm gonna speak specifically about that first summer that I was so sick and on the streets. And the arguments I had with doctors would run very much about or around the fact that I was homeless, and nobody seemed to be taking this into consideration. So I'm laying down in some cold, damp corner of concrete out here in the city somewhere to sleep at night. And I'm wondering, as a recovering AIDS patient, is my immune system gonna hold while I'm sleeping in these conditions? When it was bad enough that I do dumpster diving to have food, I'm asking myself, is my immune system gonna hold? How stupid is it that they put so much money into bringing me back from the edge of death and then put me at risk while I'm in recovery by putting me on the street? Bathrooms was a huge problem for me because you just don't have access to bathrooms when you're homeless. Most commerces will demand that you buy something if you want to use the washroom, and that's not always an option for people who are on the street. So you're fighting against security guards in shopping malls who are trying to kick you out while you're trying to get to a bathroom. But this has real impacts on my health in the sense that I am purposefully keeping myself dehydrated because I don't have that particular resource available to me. When they started putting me on a range of different new medications, and I found all of a sudden I was dealing with nausea or vomiting or diarrhea without having access to a toilet, my reaction was to take myself off the meds. When they had me on testosterone, and all of a sudden I was a 13-year-old boy running around in the body of a 50-year-old man who's homeless, I had this urge to masturbate 6 or 8 times a day and nowhere to go where I could do it. And doctors actually suggested to me that, well, if you can't find a toilet to piss in, just piss in a back alley somewhere. But pissing in public isn't any more acceptable than masturbating in public. And so I would go off the testosterone as I was dehydrating myself to eliminate the need for a bathroom. And going back and forth between all these different clinics, getting all these different tests, they would give me a paper, like old school file, to present to the next person in the chain. And I had opportunity to read through that file numerous times. And every time I went through it, I found notes about the patient being non-compliant and non-cooperative. No matter how much I tried to explain to the doctors that in my situation as a homeless person, I do not have access to the resources I need to follow your instructions, I was seen as the one who was willfully not cooperating with my treatment. And I found this shocking. And I wondered, was not so much was this information that contextualized my situation in my file with the other data, but why were doctors paying attention to the data but not the context? And that for me was a real challenge. It was something that I just could not figure out a rational reason to substantiate that. So for me, there's also a question, and one I ask myself very often during this period in my life: why am I even bothering? Like, why talk to my doctors about this if they're not listening? And is it even intelligent for me to talk to my doctors about this if they're not listening? If we're not both on the same page that knowledge is data that is contextualized, and if the doctor doesn't care about the context and only about the data on the computer screen, then I'm just wasting my time. And this for me was and still is to a large degree problematic within the way that health data is used by doctors. Does that make sense?
It makes sense. Puis, ce bout-là, j'avoue, Farin, de ton histoire, ça me fait vivre plus de la honte. Parce que moi aussi, j'ai été ce genre de médecin-là qui se dit, en réfléchissant à certains de mes patients, ben là, c'est pas des bons patients parce qu'ils n'ont pas fait ce que je pense qu'ils devraient faire pour leur santé. Je me rappelle d'une patiente en particulier que j'avais acceptée sur la liste des patients dits vulnérables, puis que j'ai jamais vue pendant 3 ans. Elle se présentait à aucun des rendez-vous. Tout ce que je recevais, c'était une femme de mon âge. Tout ce que je recevais, c'était des rapports d'hospitalisation, des rapports de visite à l'urgence pour diabète débalancé, insuffisance cardiaque débalancée. Puis j'ai tout essayé, ce que je pensais qui était nécessaire pour essayer de prendre contact, comprendre qu'est-ce qui se passait. Je l'ai appelée, j'ai offert de me rendre à domicile, elle ne voulait pas. J'ai mobilisé toute l'équipe interdisciplinaire, la travailleuse sociale, l'infirmière praticienne, la pharmacienne. Il n'y avait rien qui fonctionnait. Jusqu'au jour où on a eu la chance d'établir un contact entre elle et quelqu'un qui était entre nous deux, en fait, qui était capable à la fois d'écouter sa perspective comme patiente, puis notre perspective comme équipe de soins, pour nous aider à en comprendre, en fait, que c'était à la fois un 6 et un 9, pour essayer de voir dans les deux perspectives quelle était la situation, le problème. Puis qui a d'abord rencontré, qui est une patiente, une père accompagnatrice comme toi, Farin, qui a rencontré cette dame-là simplement en lui disant « Je ne suis pas une professionnelle de la santé, je veux simplement vous connaître, parlez-moi de vous, dites-moi qu'est-ce qui est important pour vous. » Puis soudainement, le contexte, la vraie situation est apparue sur qui elle était. Une femme qui vivait dans une pauvreté extrême, qui ne voulait pas que j'aille la voir chez elle parce qu'elle avait honte, elle ne voulait pas voir dans quelle situation elle vivait, qui ne voulait pas rencontrer la travailleuse sociale parce qu'elle avait déjà eu des enjeux avec la direction de protection de la jeunesse pour ses enfants, elle avait déjà eu des problèmes de consommation dans le passé, elle avait peur que l'équipe de soins amène des problèmes plutôt qu'amener des solutions, puis ça créait beaucoup de méfiance. Donc, la première tâche qu'on avait à faire, c'est d'abord apprendre à se connaître, apprendre à s'écouter, puis tranquillement laisser la confiance se bâtir entre nous. Quand on a mieux compris qui elle était, que dans le fond, elle tenait à sa santé, elle était super préoccupée par son diabète, elle avait peur de perdre la vue, pas pouvoir voir grandir sa petite fille. Mais tranquillement, on a pu entrer en conversation avec elle. Puis la père accompagnatrice l'a invité à rencontrer notre équipe, où là, on a pu discuter sur ses problèmes de santé, lui expliquer avec ses enfants qu'est-ce qui se passait. Puis elle s'est transformée en 2 semaines. C'est devenu une de mes meilleures patientes. On se faisait confiance. Elle s'est mise à me texter quand elle avait des questions par rapport à son diabète, tout ça. Puis ça a tourné du tout au tout. Pour moi, c'est l'intervention la plus miraculeuse que j'avais vue en 20 ans de carrière. C'est l'intervention de quelqu'un qui nous aide à nous comprendre. Puis pour moi, ça nous pointe vers, parce qu'on a discuté aussi, pas juste des problèmes, mais des solutions. À quoi ça ressemblerait, dans le fond, un monde meilleur? Puis ça, c'est la petite image qui nous est venue, l'idée de dialogue, de connaissance inclusif. What would this look like for you, Farin?
Actually, it looks very much like what you just recounted. I'd have to say that, for me, what we refer to as a health system is a bit of a misnomer. It's a medical system. For me, if we're talking about health, there are a minimum of 4 actors sitting at that table. One is physical, one is emotional, one is mental, one is spiritual. And all 4 have to be working in tandem for me to experience good health. So already I'm looking at that table and I'm saying, okay, but we need also somebody there that's talking about the social determinants of health, because it's not all about me. I am a member of the community, and I can function within that community dependent upon what resources are available to me. And if the resources aren't there, then I can't, what's the expression I want? I can't carry the weight of my responsibilities. So I need the 4 actors that are health actors. I need somebody at that table that's talking about the social determinants of health. Because, as we all know, medicine has progressed through many different stages over the year, from the time we thought about considering the miasma in the room to the time we started thinking about, well, maybe we should wash our hands in between patients, to a time we started thinking about, well, maybe there's germs, there's some kind of agent carrying this, to the times we thought about, well, you know, maybe given that all these infections are happening in that corner of our community, we should be looking at the water pump over there and seeing if germs are being carried in the public distribution of water. So all of those actors have to be at the table for me. I've questioned very much why what we call a health system only addresses the one factor of medicine. And I actually heard something really interesting a couple of weeks ago that caught my attention, because the person I was listening to was speaking about the divide within the medical industry, where doctors are treating illness and nurses are treating patients. And that rang so true to me when I thought of all of those complications around my Kaposi's, where the doctor was hell-bent on amputating my foot, and it was the nursing team that found the solutions that allowed me to keep my foot. And that means I want nurses at the table also. Doctors by themselves is not enough for me. I'm asking myself very much over the last 10 years, why is our approach not more global? Which is the reason I've put myself in Ghislaine's position of being a peer worker, so I can facilitate this kind of contextualization of data, both for the doctor and for the patient. And when I think about trust and think about who do I trust in all of this, certainly the more people I have at that table, the more likely I am to find allies. And so for me, having all of these multiple perspectives represented at the table is extremely important. I'm responding well?
You're amazing.
A last reflection on this is sort of the divide between social services and health system. Because I see social services as being very much part of the health system. Within my own knowledge and my own experience, I have learned that everything that I know, every point of data I know about health, about what I'm choosing to eat, what kind of exercise I'm choosing to do, what kind of support do I need in terms of medication or the braces that I used to wear when I was working. All of these different factors have to be put together to create what one might call knowledge. That data itself is not enough. It is the contextualizing, it is the bringing together of all these different perspectives. The doctors who's seeing, you were seeing the 9 and the patients who are seeing the 6. Like, we really need to get past that. Because for as long as we're only looking at data and not the context, that division is going to stay there. And that division is sort of systemically there when we divide social services from healthcare. So I'm encouraging people, yes, you know, go to the table, interact with others, find the way to make that division between I see a 6 and I see a 9, and turn that division into, okay, we both understand our different perspectives. Now we can go forward with a plan.
Moi, j'ai peu de choses à ajouter, Farin. La première, c'est que c'est d'abord se rappeler qu'est-ce que ça veut dire un dialogue. Et pour moi, un dialogue, c'est une conversation dans laquelle chacun d'entre nous commence d'abord par écouter. Un dialogue de connaissance, c'est un dialogue qui commence par la reconnaissance, par une posture d'humilité, par la reconnaissance d'abord de ce qu'on ne sait pas, et le besoin d'ouvrir la table pour inclure des personnes qui savent autre chose que ce qu'on sait. Se rappeler que personne de nous ne sait ce que nous savons tous ensemble. Puis, c'est à peu près ça, en fait, pour moi, des dialogues inclusifs. Ce que j'aime aussi, c'est l'idée, c'est avoir la patience et prendre le temps d'apprendre à se comprendre en reconnaissant qu'on parle différents langages et que c'est normal que des données qui ne semblent pas aller ensemble, ce n'est pas juste l'intégration dans une base de données unique, c'est aussi d'autres façons de voir le monde, c'est peut-être d'autres façons de le lire, de le comprendre à travers d'autres valeurs, d'autres perspectives, et que ça demande du temps. Et que ça, parfois, ça demande l'aide de traducteurs, d'ambassadeurs qui parlent plusieurs langues pour qu'on puisse avoir une vision qui est plus globale de ce que veut dire la santé, puis comment l'améliorer. Moi, c'est ce que je retiens de notre dialogue à nous deux, Farin. On a des remerciements à vous transmettre, d'abord à nos collègues Vera et Gwen Vael qui nous ont beaucoup aidés à entrer, nous deux, en conversation l'un avec l'autre. Ça nous a pris beaucoup de temps puis je pense que c'était un travail qui nous a beaucoup aidés.
And we would like to thank Frank Gavin, Tasha Rani, and HDRN Canada for the invitation to present before you.
Farin, moi, je veux te remercier pour les histoires personnelles que tu nous partages, puis qui, moi, m'aident à ouvrir les deux yeux, puis soudainement voir avec un regard un peu plus large.
And for my part, I thank you, and I thank all of you here, because having this opportunity to talk about these subjects is so important, not only from my perspective as a peer worker, but also from my perspective as a patient who was unable to have really enriching dialogues with the doctors I was dealing with in those moments. So thank you, all of you, for your listening and for your attention.
Whew. Wow. The authenticity, the vulnerability, and the inspiration, exceptional. Just absolutely beautiful what we heard this morning. And to each of you, we say thank you. Thank you so much for sharing. And now we have an opportunity to take questions. I think we have a microphone in the room here. We do have a microphone in the room, okay? And we will get that moving. So if you want to stand up, and we'll bring the mic to you. And we also are taking questions online as well for those of you watching online.
Thank you so much. Can I ask something in? Hi. One just thank you very much for your stories. Like the story is like so incredibly important for Indigenous people. So I just have a couple of reflections, but I do have a question. One is, I do think that we have to lean into the conversation around social determinants of health. We've been talking about, and we know this empirically, those that have housing, a job, and food live longer. So why aren't public health agencies, why aren't they working with our economic development agency and looking at doing or working with housing? Where are those connections? And what you're doing is illuminating on an individual level, but there's a systems breakdown in this fracturing around social determinants of health and how we in public health are actually not doing a right job because we think, oh, economic development, that's their lane. But we know that that is a health indicator. And so then on a very personal level, and what I'm hearing is for training and the need for leaning into that relationship, that you are centering of a relationship. And Teddy and I will be talking later about how we do it within data. But one is, what I'm hearing is a narrative of curiosity. And y'all may want, as a care practitioner, curiosity of giving a damn of the person that's in front of you. And I think I heard that narrative so powerfully. And that's where you get trust in relationships. Or do we develop more and better cultural competency training, the hard skill set of say this, don't say this? Or is there a third and fourth way of how do we resolve these tensions? How do we center relationships within a data as well as a people first, right? And how do we move, go forward, right? Because I think that right now we're vesting into, and I remember for the last 20 years of doing cultural competency training, thinking that I'm going to take a 4-hour work class and I'm going to learn how to walk in someone's shoes that is white, male, cisgendered. I'm not going to be competent. And so how I approach the world is to do curiosity of who are you? And so so that's how I navigate this system, to giving a damn. And I love we were talking about our words for non-native people, trauma-informed care. I dug into that conversation so hard of what does the lit say? And then I realized that trauma-informed care is just saying love in a professional setting, but not using the word of love. Come on. Trauma-informed care is giving a damn for the person that is sitting in front of you. A relationship and love. We don't have trainings for that. Let's be honest with each other. You're absolutely right that for care, we need a relationship, that social context. But how do we know it? Just like we know social determinants that is a driver of health. Yet we do nothing to actually promote housing, work, and food.
Can I pick up on, thank you for your comment. When we prepared for this talk, I was actually freaked out, about the invitation because I don't know anything about data, and we set out on a plan, Farin and I, on saying, well, we're just going to leave the audience with questions, no answers, and but there is one particular question that you've asked, and for me, in my life, it's been very key and powerful, I found, is who are you? And in medical training, when I teach medical residents and they meet a person for the first time, in the medical culture, it's called prise en charge, taking charge of the patient. And the one thing I tell systematically to medical students is, can you reframe this as a first meeting with a person? Maybe the opening question could be, who are you? And listen. And that works in clinical practice, but it also works in any kind of setting. My colleague Ghislaine was mentioning to you, we've been approached by a team in Japan, researchers and citizens and social scientists. And At one point, they came over to Montreal. We had dinner at our place, and the question was, "Who are you?" And then, they revealed themselves, grandmother, mothers. We connected at the human level beyond our roles, our masks, and that's how we found the connection between all the differences from the outside. And we started relating with one another, and then you find that you can work together. So for me, this is the "who are you" question is very key.
Thank you for that. We'll take another question in the room here, and then we've got one online. We'll go online first. Would you like to try the first online question that's posed in French there? Would you like that?
Oh my God. Docteur Boivin, j'aimerais savoir ce qui vous a inspiré d'avoir une vision holistique de la santé, des idées sur comment transmettre ça à nos... I don't know. Je pense que c'est juste... Je sais que la raison pour laquelle je suis allé en médecine, c'est pour rencontrer des gens. C'est qui je suis. How do you share it? I don't know.
And that's okay. Yeah. That's okay. We have a question up here at the front.
So thank you both for your time today. It was an amazing talk. So I want to actually, upon reflecting and listening to your talk, so my background, so I'm trained as a physiotherapist and I work in acute care. And one of the things that stuck out to me, Farin, is you said, doctors treat illness, nurses treat the patient. Even in my training, social determinants of health and the biopsychosocial model was very, very emphasized. So, my guess is it's also emphasized during the medical training. And this is more of a question for you, actually, doctor, is how do you feel like the medical training is supporting these types of conversations that medical students, residents are, I guess, feeling confident to engage in? Or do you feel that we do support these types of conversations that could happen? Are they afforded the time and availability and the support to start to engage in these, or do you find there's competing pressures that sort of disincentivize them?
So do I understand well that is how do you...
Yeah, I guess to dial that down is, do you feel that these types of conversations are supported in the current medical training model, and do you feel that...
And is the question for me?
For you. Actually, both. In fact, I'm happy for either
Farin,
one.
you have ideas?
Yeah.
Go for it.
I switched doctors near the beginning of the COVID thing because I was determined that I wasn't going to get that jab. And by my own estimation, my doctor was being uncooperative, so I found another. And I think over the last 2 years, having visited every 3 months, so that's 8 visits in 2 years, I've probably spent a grand total of about 15 minutes in conversation with my doctor. She comes in, she tells me what I'm going to do. She points at a computer screen at a number saying, "This is why you're going to do it." And that's the end of my appointment. And that whole idea of having a conversation with my doctor or an exchange with my doctor just is not there. I feel like an errant child being disciplined by a parent. And this doctor is probably 30 years younger than I am, which is really even more offensive. So, yeah, this really has to happen. This phrase, prise en charge, is something I detest. From my position as a peer worker in harm reduction, I'm all about empowerment. I'm about people taking responsibility for their own choices in life. And the idea that I'm going to send somebody to a doctor who's going to take them in charge and treat them like an errant child, I find that I'm often in an ethically really uncomfortable place as a peer worker. And I don't know how that changes. I know that it's changed for me radically in my work environments, that I have conversations with doctors all the time, with nurses all the time. I feel that I am well respected. I feel that I am acknowledged. I feel that I can accomplish something for the patient. But in my own personal dealings with my personal doctor, I'm very far away. Although I treat her as I would treat any doctor when I'm representing a patient as a peer worker. So there's something being lost there. My doctor does have all the information, she's just not putting it in context herself.
OK, I've had time to think now. Je pense que les choses qui m'ont influencé le plus, qui m'ont le plus marqué dans mon parcours, c'est tout ce qui s'est passé en dehors, en fait, de ma formation médicale, puis des soins, qui m'ont permis d'entrer en relation avec des patients ou des personnes à l'extérieur du contexte de soins. Une des expériences, quand j'étais étudiant en médecine, j'ai commencé à être bénévole dans un camp de vacances pour les jeunes qui vivent avec le cancer et leurs familles. J'étais incognito, personne ne savait que j'étais médecin. J'avais mon nom de camp, Joyeux Luron, j'avais ma guitare, je chantais sur le feu de camp avec les ados, avec les parents, puis j'écoutais leurs histoires en passant, puis ça m'a ouvert les yeux sur tous les soins, le prendre soin qui existait à l'extérieur de la clinique. Les jeunes qui s'aident entre eux, les parents qui se donnent des conseils, qui se réconfortent, tout le travail de reconstruction identitaire, l'impact sur la famille, sur l'emploi, etc. Ça m'a beaucoup ouvert les yeux. Une autre expérience, ça a été de vivre dans une petite communauté rurale où j'ai commencé à pratiquer, où l'image que j'ai, c'est mes patients étaient en 4 dimensions. Ils avaient un nom, ils avaient une histoire, ils avaient des relations. Hein? Le patient, ce n'était pas juste un nom avec un dossier, c'était aussi le voisin, l'ami, le cousin de l'infirmière. Moi, j'avais mon petit groupe de musique traditionnelle, on jouait. Tu sais, les gens avaient une identité haute. Je me souviens du fils d'une patiente aux soins intensifs. On discute de choses médicales. Le soir même, c'est le conducteur de taxi qui me ramène de l'aéroport. Donc ça m'aide à voir qu'il y a une personne aussi derrière la jaquette bleue, hein, derrière le dossier médical en 2 dimensions. Il y a une histoire. L'autre expérience transformative, c'est moi-même devenir malade. Puis là, wow! Voir le système de santé que je pensais connaître dans les souliers d'un proche aidant ou d'un patient. J'ai comme réalisé qu'il y avait je ne savais pas être un patient. Je connaissais le système, mais dans les souliers d'un médecin. Puis une dernière, c'est avoir des patients comme collègues, puis d'avoir des conversations autres que je ne connais pas ton dossier médical, Farin, mais je te connais comme personne. Puis ça a complètement transformé ma vision d'une personne qui a déjà vécu en situation d'itinérance ou qui a des problèmes de santé, ou je te connais comme personne. Puis ça a un impact sur la façon dont je vois mes autres patients. Fait que ça, ce type d'expérience-là, ça pour moi, ça a été transformateur.
Thank you very much for this. So we have a comment that came in online. I'll just read it to you. You can see at the top of the screen. It says, not a question, but thank you for acknowledging the role of nurses in advocacy. The nursing model of care is so vital, and I think many people do not realize how much it differs from and complements the medical model. And the question that follows that, and I'm sure it's an easy answer for you, is how should we relate to power imbalances in dialogues? And we've got 4.5 minutes left in our session.
Well, for me, that's easy. That's why, as a physician, I say that a dialogue starts with listening.
And I guess I could say that a dialogue starts with speaking also, because I've been known for many years as somebody who will not shut up. I will keep protesting. I will keep fighting. I'm going to, change something here. But I know that with many of the people I work with who are for the most part, people with addiction, drug addiction problems, and largely homeless or living in some kind of extreme poverty. Trying to get them to speak up for themselves is very difficult. Trying to get them to understand that empowerment and taking responsibility for yourself means that you actually have to get out there and fight is really difficult. I had a moment the other day I was accompanying somebody who was trying to convince me while we were working with the social worker that I don't have a problem, the government has a problem. The government is going to fix this problem about my housing when they do, and until then, I believe in Jesus, Jesus will care for me. And it's the kind of dependent attitude that is really difficult to overcome when you want to have a dialogue and you have to go through uncomfortable moments in that dialogue. Even when I'm uncomfortable with Antoine or any of the other colleagues I work with, I still feel safe. And many patients do not feel safe. They feel oppressed. And that's something that needs to be addressed from the patient's point of view, is that it's okay to tell your truth. It's okay to make demands. It's okay. It's actually the biggest respect we can show towards the Creator to do everything in our power to protect our well-being. And so both sides of the equation need to work on how they're going into dialogues.
So as we move to conclude towards the end of this session, I'm going to ask the final question to you, Farin. I'm going to put you genuinely shared such a story, your journey, and I think on behalf of the room here, how are you today?
That's a really good question. And I don't know if I have a good answer because I question that a lot myself. The AIDS hit when I was 49. By the time I was on the street the next year, I was 50 years old. And I've spent most of the last decade trying to figure out, how am I? Because I have a really hard time separating things like chronic fatigue. Am I feeling fatigued because I never properly recovered from that medical episode? Or am I feeling fatigued because I'm now middle-aged? And so many people have told me that, the 50s was the time that they saw their energy decline the most, et cetera, et cetera. So I'm not sure whether I ever recovered really well and then started into a middle-age descent in terms of vitality, or whether I just never recovered at all and I'm still stuck in some kind of medical chronic fatigue thing. I definitely made a career change after that experience. Part of what I was going through while I was on the street was questioning, what am I going to do now? Because up until that point, I had worked as a freelance agent in the fashion industry. My work weeks were extremely long, extremely chaotic. I knew I couldn't go back to that, but then went through a process of retracing, well, what were my concerns in fashion? And for me, my concerns were related to fashion and how it works both as a catalyst for social change and an indicator of social change. So from there, I asked myself, well, where can I go now, given my disability, if you like, to foster social change? And for me, that question was answered with the presentation of people around me that were suggesting I should do peer work. And peer work left a lot of room for me because I have experienced homelessness, because I have experienced cancer, because I am a homosexual man. So there's all sorts of opportunities to do peer work. And for me, it came down to where do I want to do the peer work? And for me, that answer came to this idea of dialogue with the doctors. Let's get everybody on the same page before we go into medical interventions and how those are going to impact people.
Thank you for the additional insight.
I'm feeling very positive.
Good.
I'm feeling very good. And I'm also feeling like, I'm just going to throw this in, I don't want to work anymore. So my goal has become, I want to do whatever I can as a peer worker for the years left to me. I'm probably 5 years away from retirement, to ensure that by the time I retire, we don't need peer workers anymore. That there are multiple actors at the table within the context or within the framework of a medical intervention that can work together to provide the best possible care for patients and to encourage trusting relationships, to encourage that people can take the responsibility for themselves of making good health decisions without being treated as a child. And if we can get there so that my job isn't necessary, all those people I'm going to make unemployed are proof of a job well done.